Okay, now we're going to talk about magnesium. And magnesium is a really important electrolyte because it's actually involved in many different physiologic reactions throughout the body. You don't really need to know the specific ones. You just need to know that it's frequently used as a cofactor for different enzymes and stuff to allow our body to regulate itself and maintain homeostasis. Having an appropriate amount of magnesium is very, very important. Magnesium also serves a role as an electrolyte that inhibits the ROM-K channels. So these are the renal outer medullary potassium channels that we've talked about in the nephron transporter series. But remember, we essentially have these channels that potassium can go through. These are ATP-dependent potassium channels, most commonly seen in the collecting duct, and they will push potassium out into the lumen to ultimately be excreted from the body. So essentially at baseline, our magnesium inhibits this channel. That is going to allow less potassium to be secreted from the cell and ultimately excreted from the body. However, if we wipe out this magnesium or we decrease the levels of the magnesium in the body, we are going to have less of the electrolyte that inhibits the channel. So it's kind of like an inhibiting the inhibitor sort of scenario. And thus, more potassium is going to be secreted from the cell. I'm drawing here in blue. Remember our terminology. If we're going into the lumen, into the urine, that is secretion from the cell, and then ultimately excreted from the body, I would draw in orange here. This would become urine that is ultimately going all the way through the nephron, through the collecting duct, to come out as an excreted substance. So it can make sense to us then why hypokalemia can persist in the setting of hypomagnesemia, because if we don't have this molecule, if we don't have this electrolyte that inhibits our potassium secretion, we're going to secrete more of that potassium and ultimately continually excrete it from the body and continually have a low level of potassium. So that's why sometimes they will say that you can't actually correct a low potassium level until you correct the low magnesium level. And that's what I'm highlighting over here. Potassium will not correct until magnesium is corrected, and this is why. So first let's talk about high levels of magnesium or hypermagnesemia. The primary causes, one of which is renal failure. So if we have a normal healthy kidney, right, that looks like this, and then we have kidney disease, chronic kidney disease, and renal failure, we get kind of this shrunken appearance of our kidney, and that is going to decrease our filtration of substances, which should make sense that this could cause an increased level of magnesium in the body. If we're not able to filter this electrolyte and keep our homeostasis, it can build up, much like many other electrolytes can build up as well in the setting of renal failure or chronic kidney disease. The next one that's important to know is rhabdomyolysis. So this is essentially breakdown of the muscles in the cells in the body that can cause a significant release of magnesium. So typically our intracellular amounts of magnesium are much higher than our extracellular amounts. So we have a big Mg inside the cell and a small Mg outside the cell. However, in rhabdomyolysis, we get that muscular damage and that cellular breakdown, and this is essentially going to cause the cells to lyse or break. And when they do, this allows our magnesium to essentially leave the cell into the extracellular space, and thus this can cause an elevated level of magnesium in the serum, which is what we're typically measuring on our lab values. And finally, the third one I think it's important to know is an increased oral intake. So this should make sense to you. If a patient is having significant increases in the amount of magnesium they are consuming from a supplement or a medication, this can obviously increase the total amount in the body and the serum levels. A common example of this is magnesium hydroxide, also called milk of magnesia, which is commonly used as a laxative for patients. But you can imagine if you have too much of this supplementation, which has very high levels of magnesium, this can ultimately cause too much magnesium to be in the serum and thus an elevated level on your laboratory values. Another way increased oral intake can present is a patient who is taking chronic antacids for GERD or some other pathology. These can also contain high levels of magnesium. So next let's talk about the presentation. So one thing that can be in the primary presentation of hypermagnesemia is a decrease in DTRs, which is a deep tendon reflex. We don't need to know the pathophysiology behind this. We just need to know that magnesium can actually block synaptic transmission in the nervous system. This can lead to decreased tendon reflexes on physical exam. The next thing that's important to know is that cardiac abnormalities can persist. I think this is kind of a common thing amongst a lot of our electrolytes, right? Too much of an electrolyte and sometimes too little of an electrolyte can actually cause cardiac problems. The specific ones you need to know for high levels of magnesium include an increased PR interval, QRS duration, and QT duration. These are important because anytime we have something that is affecting our cardiac cells and creating a cardiac abnormality, it's very worrisome to us because these can be very severe and ultimately lead to death for a patient. And finally, hypocalcemia is something that we can see in hypermagnesemia. So the question is why? Why is this occurring? And the reason is that elevated levels of magnesium can actually inhibit PTH secretion. Remember, PTH stands for parathyroid hormone. Sometimes we talk about the memory aid and saying that the PTH stands for phosphate trashing hormone to remember that phosphate levels would decrease, but really it stands for parathyroid hormone because it is released from the parathyroid glands. And so if magnesium suppresses PTH secretion, what is that going to do to calcium? Well, it's going to decrease calcium levels because PTH is typically released from the body in response to low calcium levels. It's acting to increase the levels in the body and reabsorb it from the bone so that more of it can be free floating in the serum. But if we're blocking that stimulus, if we're blocking PTH, that's going to block our ability to increase our calcium levels, and thus we're going to stay at a hypocalcemic or a low calcium state. Next, let's talk about the management options. So the first one should make intuitive sense, right? Stop magnesium-containing medications. We talked about milk of magnesia or antacids. If a patient is taking a lot of these, we can have them stop taking those, and that should help improve their serum levels and return to homeostasis. We can also do something that includes in combining NS or normal saline, a fluid, with loop diuretics. So remember from our nephron transporter series, we have certain parts of the kidneys that work to reabsorb magnesium and calcium and different molecules that we need. One of those primary areas for magnesium is in the loop of Henle. And a medication that we can use are called loop diuretics, which can actually block the reabsorption of magnesium indirectly. So typically we have our NKCC channel, which stands for our sodium, our potassium, and our chloride, which is bringing back molecules. This is going to then create an electrochemical gradient, which is going to push potassium out into the lumen. And ultimately, this plus charge that we create out here is going to push these molecules, which are also positively charged, paracellularly through the cells in order to reabsorb them. Because potassium is positively charged, magnesium and calcium are positively charged, this is going to create a repulsive force that pushes them through. So if we give somebody a medication called a loop diuretic and we inhibit this NKCC channel, we essentially shut down this whole process, and so that we don't actually reabsorb as much magnesium and calcium. And so this gives us a memory aid that we talk about. We say that loops lose magnesium and calcium. So if we give somebody furosemide, we can actually cause them to lose more of that magnesium through this mechanism. By blocking the NKCC channel, we indirectly increase the excretion of magnesium. It's important, however, that we also pair this with normal saline, right? Because we know that loop diuretics are given to offload fluid for patients. We're giving them to decrease their volume status. However, in these patients, we don't want to change their volume status necessarily. We don't want them to become dehydrated or volume depleted. We just want to get rid of the magnesium. So we're giving them a loop diuretic to get rid of the magnesium, but we also need to maintain their volume status, and thus we have to pair it with volume replacement, such as normal saline or potentially a lactated ringer. Next, we can give patients something called calcium gluconate. We don't really need to know the pathophysiology behind this. We just need to know that high levels of magnesium can cause cardiac abnormalities, which we previously talked about. And calcium gluconate is a medication that we can give that essentially antagonizes these effects. So they block the effects from occurring. This is very important because, again, when we talk about cardiac abnormalities and changes with heart cells and the electrolytes, these are some of the primary things that we need to treat for a patient and intervene on because they can be some of the most concerning and potentially the most deadly for the patient. And finally, in severe cases, you can use dialysis with pretty much any of the electrolytes. If there's a significant buildup, patients have kidney disease, they're unable to excrete these and maintain homeostasis themselves, well, we can help them with dialysis by essentially removing the electrolytes manually. Next, let's talk about low levels of magnesium or hypomagnesemia, starting with some of the primary causes. I think it's simple if you just break them up into GI loss and renal loss to start with, right? So anything that's going to cause us to lose levels in the gastrointestinal system or in the kidneys is obviously going to cause a low level of magnesium in the body. So these can be things such as vomiting, such as diarrhea, are going to be GI conditions that will cause us to lose magnesium. From a renal perspective, if we gave somebody too much of the loop diuretics that we talked about, this could cause them to have low levels of magnesium. Additionally, there are some congenital abnormalities we talked about in the nephron transporter section, such as Gittleman syndrome, that can also cause a patient to present with low levels of magnesium. Additionally, drugs and medications can cause low levels, right? We've already talked about loop diuretics, but also thiazide diuretics can cause it, and various other things. So it's always important to be mindful of what are we treating this patient for, and what are we treating this patient with? Are any of these things we're treating them with causing some of these new or changing conditions in their presentation? And finally, one that's always important to keep in mind is malnutrition. So Again, somebody who is malnourished, they can be malnourished for a variety of reasons. They could be due to, lack of access to food sources. It can be due to an imbalanced diet. And it can also be used to other things such as alcohol use disorder. So looking at some of the primary presentations for patients with low magnesium levels, you can get something called tetany, which is essentially muscular spasms that are occurring. Remember, magnesium is important for kind of maintaining this balance and homeostasis of neuromuscular transmission. So when we throw off this homeostasis, we can get unwanted or unexpected neuromuscular transmission. You can also get something called torsades de pointe, which is French for twisting of peaks. And this is essentially an ECG finding. And you can see how it changes from low amplitude to a higher amplitude, back to a lower amplitude. And this is very important and concerning to be aware of because this particular waveform can actually progress to ventricular fibrillation, which we know can be a deadly thing for patients. This can be caused by a variety of different things, such as low magnesium levels, low calcium levels, low potassium levels, as well as a variety of other drugs and medications. But the treatment for this condition is to actually replace the magnesium. The next presentation that a patient could have is hypocalcemia. And you might be saying, wait a minute, David, you just told us that high levels of magnesium can present with hypocalcemia. How can this be true for both? And you're right. The key here is that for hypomagnesemia to present with hypocalcemia, the levels of magnesium must be severely low for this to occur. But why? Why does it occur? We said that in high levels of magnesium, we can actually inhibit PTH. So you would think in low levels of magnesium, you would actually increase PTH release. But paradoxically, very low levels of magnesium also inhibits PTH release. So again, we get the same presentation with high levels of magnesium or very low levels of magnesium, and that PTH is suppressed and thus calcium levels are going to be decreased and we're going to continue to have a hypocalcemic state. Again, it's all about homeostasis here, right? We have something called calcium sensing receptors in the parathyroid region, and for those to work properly, they essentially need an ideal amount of magnesium. So essentially that is to say, if we have a normal healthy amount of magnesium, we are helping this receptor work. We are helping our calcium sensor work. But if magnesium gets too big or too high, this is going to inhibit the calcium sensing receptor. And additionally, if magnesium gets too low, this is also going to inhibit the calcium sensing receptor and ultimately PTH release. So really, hopefully this diagram right here helps you make sense here, in that it's really about that homeostasis and maintaining the ideal level. Too much magnesium is not good, and too little magnesium is not good. And finally, a presentation that can occur is hypokalemia. We won't talk about the mechanism again because we did at the beginning of the video, but remember, at baseline, magnesium inhibits the ROMK channels, and thus low levels of magnesium is not going to inhibit those channels. It's going to increase the amount that flows out into the urine, into the lumen, and is ultimately excreted from the body. And finally, to wrap up this pretty dense video on magnesium, the management option here is going to be magnesium supplementation. If we are deficient in something, the first thing that we can think about doing is replacing that deficiency.